Good afternoon and welcome to Open Classroom. I'm Janet Gillow, the Director of Professional Development for the Brown School, Washington University in St. Louis. So glad to have you with us today as part of the program. Throughout this presentation, our guests on Zoom are muted. We cannot see or hear you. We also can't call on raised hands, but the chat feature is enabled and we would love to have you share your comments, your thoughts and questions throughout the program. I want to send a special welcome to people joining us on YouTube. We don't have a way of directly interacting with you, but we're very glad you're a part of the program today. I want to thank and acknowledge my friend, my fellow Brown School alum, Cynthia Williams, our Assistant Dean for Community Partnerships. She's co-hosting and will help moderate the chat, representing your voice in this space as we move to the question and answer part of the program. Before we get started with today's program, I just want to let you know what we have coming up next week. 3 different programs, and I think they actually do a great job showcasing the range of things going on at the Brown School. So on Tuesday, March the 16th, we have Beth Brawley speaking to us about cultivating compassion during times of uncertainty, being kind to ourselves and others. On Wednesday, the 17th, we have the second in our series related to the COVID vaccine in St. Louis, a panel discussion regarding race, risk factors, and equity in vaccine distribution. And then on Thursday, the 18th of March, Drs. Gerard Hollins and Andrew Thiesing are delivering a talk on public administration, finance, and government budgeting. So range of topics, hopefully something for everyone. I'll throw the link in the chat. Definitely encourage folks to join us for today's program. So it's my great pleasure to introduce Dr. Ross Hammond, who's the Betty Bofinger Brown Distinguished Associate Professor in Public Health and Social Policy at the Brown School. He's also director of the Center on Social Dynamics and Policy and a senior fellow in economics at the Brookings Institution. His research applies complex system science to challenging policy problems. And he's currently focusing on a range of things, including pandemic containment, obesity, tobacco control, the food system, health disparities, and decision-making. His work has appeared in journals like Lancet, Science, and the Journal of American Medical Association, as well as the popular press, NPR, the Wall Street Journal, and the Atlantic. In addition to his role at the Brown School, he holds appointments at the Harvard School of Public Health, the Santa Fe Institute, and the Australian National University. And after his comments, Ross is going to be joined today for Q&A by Washington University alumnus and epidemiologist for the city of St. Louis, Matt Haslam. So here to speak to us about modeling robust containment of COVID-19 in the face of uncertainty, please welcome Dr. Ross Hammond.
Thank you so much and welcome everyone. I'm going to go ahead and share my screen and we'll get started. So my goal is to give you a bit of an overview today of a project called TRACE, which is a computational modeling project designed to assist policymakers in choosing interventions to contain the spread of COVID-19, given all the uncertainty that we as a country face about COVID-19 and the underlying virus that spreads it. And to do that, I'm going to first give you a brief disclaimer that although I do hold a number of advisory appointments in the federal government, nothing that I say today should be construed as any kind of official position of any of these groups. They're just my own opinions. I'm going to give you a bit of background about where I see us being as a country right now with this pandemic, and what some of the challenges that have confronted policymakers all along are, and how they are still relevant today, how models can help us with these challenges, what this specific model called TRACE is about, some work we've done at the national level earlier in the pandemic with this model and what those findings were, and some work we've done very recently in partnership with the St. Louis Health Department to apply the TRACE model locally and what some of those findings are. And then I'll leave a lot of room at the end for questions and discussion of any of the things that I've covered. So the context here is, as many of you know, we have an accelerating rollout of some very effective vaccines. And that's very exciting, but it still is going to take quite a while to get enough vaccination out to stop the spread of this virus. And in the meantime, we have a bit of a fraught period to contend with. We have limited evidence about how much the vaccine is actually going to contribute to stopping transmission versus just stopping disease for the people who take it. We have these new variants that have appeared of the virus, which may be more contagious, which may limit the effectiveness of the vaccine in some cases. And I think everyone will identify with the idea that we are all experiencing some fatigue with social distancing rules. And in many parts of our country, those rules are being lifted as we speak. And it's not at all guaranteed that that everyone in the United States will want to or be able to take this vaccine. And given all of this, we have a challenge in the short run before we get enough vaccination out there in figuring out how to continue to keep the case account for this virus going down, not coming back up, and avoid a fourth wave that would be very costly to our country. There's a number of challenges that have been with us all along as we tackle COVID, and they continue to be relevant today. The first of these is that we have to balance containing the spread and the actions we take to do that with the costs that those actions have for society. The bottom line is that until we reach herd immunity, whether through vaccination or enough people having recovered from COVID and being immune, the risk of spread will continue. And one way that we have used as a country in the past to contain the spread is through mass social distancing, through closing businesses and schools and shelter-in-place orders. But those come with a very high cost to society, economic costs, social costs. Meanwhile, we know that from the example of other countries and some cases within our own country, that testing and contact tracing can be effective ways to allow us to reopen while containing spread, but they require investment and consistent application to work. We also know that masking and individual social distancing can help, but they only help contain widespread virus if enough people do them regularly. So there's a balancing act here. The second challenge is that all of these policy options come with many specific implementation choices, and they interact with each other, which makes it very complicated to navigate through this immense landscape of possible policy configurations to find what's going to work best. So for example, if we think about testing and contact tracing for a second, if one is a policymaker wanting to implement testing and contact tracing, one immediately needs to answer questions like, how many tests do I need? And how accurate do those tests have to be? Who should I give priority to for getting tested for COVID? What blends of test technology should I be using? PCR tests, antigen tests, all these different things. How much contact tracing capacity do I need to invest in? How long should I ask people who may have been exposed to COVID to self-quarantine for? And how much adherence should I expect to quarantine? And the right answers to all of these questions might, of course, depend on things that we are still uncertain about COVID, the disease, and the underlying virus that spreads the disease. And that's the third challenge. There's these ongoing and changing uncertainties about COVID and about SARS-CoV-2 itself. Early in the pandemic, a lot of these uncertainties were things like how many cases are asymptomatic and how much of the spread is going on that is driven by asymptomatic cases. Why are there so few cases in general and so few serious cases in particular in children? And what does that mean for school reopening? Who's really at risk? Those were all things there was a lot of uncertainty about. More recently, we've added additional uncertainty about all of these new variants that are emerging of the virus, and uncertainty about what the vaccine does in the way of helping prevent asymptomatic transmission as opposed to just preventing disease. And the fourth set of challenges is that we are a very diverse country. There are important differences across people and local contexts that shape the right choices, quote unquote, from that policy menu. These include social and demographic factors. They include biological factors. And one of the important findings early in COVID was that even among different people who have a similar degree of infection of COVID, there is a differing propensity to spread it to other people, different amounts of infectivity. And that matters quite a lot for the dynamics of how it spreads, as you would imagine. And finally, there's lots of geographic and political factors that shape what is a feasible option from a policy perspective in different places in the country, and the scope of policies when they're put into place. How can models help with all of this? Well, in three ways. The first is that models can be virtual laboratories, petri dishes for policy, if you like, that allow us to do experiments we could never do in the real world because they take too long or they would be unethical or too costly. And we can experiment with a huge range of different policy options, both to capture synergies between them. So if you think about testing and contact tracing, when we do contact tracing, what we do is we identify someone who we think has COVID. We ask them to name all the people they may have had close contact with, and we try to contact those people to warn them that they may have been exposed to COVID. If we're doing a lot of testing of people who don't have COVID, or the testing is misleading about who has COVID, then we're using up a lot of tracing capacity, and our capacity doesn't go as far. So there's synergy between efficient use of testing and tracing capacity. Similarly, there might be substitutability that we want to understand. So we might want to answer questions, as we indeed did earlier in the pandemic through a lot of the country. How good does our capacity to do testing have to be to safely open schools and workplaces? So can we substitute more testing for less closure of schools and workplaces? Those kinds of things are things that a model in a virtual world can help us explore very thoroughly. The second thing that models can do for us is that they could be decision support tools to help policymakers manage all this uncertainty I talked about earlier. What we really want to know in the face of uncertainty are what are some things concrete things we can do as policymakers that are robust to that uncertainty. That is, they're expected to perform well, even with very pessimistic assumptions about all these things we're unsure about. And also, as a side project to that, we'd like to know, of all the things we don't know, all the uncertainties, which are the most important ones, which ones matter the most for the way in which the spread of COVID happens. So if we have a limited amount of ability to collect new data, where should we be focusing that energy to help us be more sure that we're making the best policy choices possible? And the third way that models can help, and not all models are as good at this, but some models can do this very effectively, they can help us tailor to context, to understand how to translate what worked in one country or one state or one city to a new setting. And they do this by capturing enough of the diversity that I talked about earlier across people and across settings, that they can help us identify the subset of policies that are best suited for different groups or different places. So the TRACE model was designed to leverage all three of these advantages that models give us in confronting the uncertainty of the policy landscape in containing COVID. TRACE stands for Testing Responses Through Agent-based Computational Epidemiology, which is a long name, but I think it's important to highlight three things about TRACE that set it apart from many of the other models that are out there. And everyone in the country now has heard a lot about models throughout this long year of pandemic. There are all kinds of models, all different approaches to modeling, all different purposes for models. What is it about TRACE that is specific, and specifically its focus? The first of these is that TRACE is not a forecasting model, unlike many of the other models out there. Instead, it really wants to leverage this idea of models as being a policy laboratory to explore not what is today, or even where we're heading in the short run tomorrow, left to the status quo, but what could the world look like if we did any number of different kinds of policy interventions. And indeed, in our national level work, we explored over 10,000 different combinations of policies to see what they might do. The second thing that's different about TRACE is that many models are based on a subset of assumptions that are drawn from the best available evidence, and they bake those assumptions in and run with them. And that's a fine thing to do, and it serves many goals. But in TRACE, we actually went the other way, given the amount of uncertainty, is we actually systematically vary all of those assumptions that we're unsure about. And the purpose in doing that is to help policymakers find policies that are robust to that uncertainty, as I talked about earlier. And the third thing that's different about the TRACE model is that this is an individual level model. So we actually represent each individual person who is in the simulated area with their own individual in the model. We don't group them into categories or compartments or buckets or any other kind of aggregation. And because we're representing each individual independently, we can have lots and lots of diversity between individuals. And that's really important for how COVID-19 spreads. I'm going to talk about two versions of the model and applications of it briefly here. The first was some national level US, whole of US work that we did earlier in the pandemic and then updated relatively recently as part of a briefing to the US Congress. And this model, this version of the model, has a population that is demographically representative of the entire United States. It simulates the spread of a virus, the virus that causes COVID-19, via contact between people. And the contact is shaped by the activity patterns that people engage in, where they go, where they work, who they see. And those in turn are driven by what age the individuals are and categorized by setting in a way that's based on data. So each person in this model has a network of other people who they have contact with. In this picture that I'm showing you here, each of the dots is an individual, and the lines between them represent contact between two individuals. The size of the dot in this particular representation of a very small part of a population, it represents the age. The color represents the spread of COVID through time, so different disease states, sick, healthy, recovered. And the kind of line that connects them represents the setting in which this is happening, in school, in work, at home. Where does all this information come from? Well, it comes from big studies that we drew on that map the amount of contact between people of different ages in different settings. So as this picture shows you, both the x-axis and the y-axis of each of these plots shows a different range of ages from 0 through 80. And the density of the color at the intersection of those two is the amount of contact between them. And the pattern looks very different at homes, in workplaces, in schools. So we build that into the model. The model of COVID itself is what's called an SEIR model. I won't get into the details of all the different letter acronyms that people use for these kinds of models. This is a very common way to model COVID. It's important to say that our model does take into account asymptomatic cases of COVID as well as pre-symptomatic spread of COVID, people who have not yet experienced symptoms but are able to spread COVID. And those things, as we know, are all very important for COVID. And we draw on lots of data to make these representations of the progression of COVID. Then we use this model, which I'm happy to go into more detail, by the way, in the questions about the inner workings of the model. What we use it for, which is what I really want to focus on in this presentation, is to be a policy laboratory, as I alluded to earlier. And in this version of the model, we are looking at social distancing policies, which include school closure, workplace closure, or shelter-in-place orders. We're looking at testing policy dimensions, which include the amount of tests per day of PCR tests, the accuracy of those tests, the amount of contact tracing capacity, who gets priority to be tested, the quarantine protocol, and the adherence to quarantine. This work was all done before there were vaccines, so vaccines are not part of the work that I'm showing you here. This was earlier, but overall, we simulated over 160,000 different scenarios that co-vary all of these different policy options with all these underlying assumptions about the epidemiology. And we have a number of key findings that I want to highlight here because many of them are still relevant today, even though this work was done some time ago. The first is that we can and should be aiming for true suppression of COVID, not just flattening the curve, but actually containing cases down to the point where they virtually disappear over time. And in the model that we did at the US level, we actually found that you could do that without mass closures of everything if you invest in enough testing and contact tracing. The second key finding is that policies have to consider this idea of robustness. So these four graphs show the percent of people infected on the y-axis over time, on the x-axis, for the same policy under four different sets of assumptions about the underlying biology and epidemiology. And what you can see is that this is a policy that works great in the upper left-hand corner if you assume favorable things about the epidemiology, and doesn't work very well at all in the lower right-hand corner if you assume very unfavorable things, and it works differentially well in the in-between assumptions. So this stresses the idea that policies really do have to take uncertainty into account to make the best choices possible. The third finding from this work was to really underline how important adherence to quarantine is. So in this model, we find that if you assume that most people, and even very high percentages of people who are asked to self-isolate for 10 days are able to do so, and do so, in fact, then you have many policy options that can work well, as shown by the green curves. But for many of those same policies, if too few people are willing to or able to self-isolate for that 10-day period, then those same policies don't work, and you have many fewer that do. And so that's actually an important policy goal in its own right, to help make sure that any American who needs to self-isolate is able to during the course of this pandemic. The fourth key finding from this national level work was that prioritizing people with symptoms for testing is not always a great idea. In fact, if you have limited amount of testing, there may be many more efficient ways to use the testing. And we identify what some of those are in the work. There are many, many more results, more than I have time to talk about here. We did set up a public website that tells you all about this work, the original TRACE US work, and it comes with this thing we call a dashboard where you can dial in any kind of a set of assumptions that we looked at, and any kinds of policies that we looked at. And it will draw on our simulated data to show you the projected outcomes from that combinations of policies and epidemiological assumptions. And as I said earlier, we did millions of different simulations, and you have access to all of them to explore in this dashboard, which we can certainly send around the link to again later. But I have more to say, because that was the national level work. And now I really want to talk for the rest of the time about the St. Louis specific work, given the audience for this particular presentation. We did undertake a very collaborative effort to tailor this TRACE model from the national context to the St. Louis context. So we worked really closely with the St. Louis Department of Health to do this. And I'm actually going to be joined by an epidemiologist from the St. Louis Department of Health who was very involved in all this work that I'm about to show now to help me answer questions at the end of this presentation. We did a number of things in collaboration with the Department of Health. One of them was to try to appropriately represent the current conditions and sets of policies in place in the St. Louis region, including the ongoing vaccine rollout, to identify the most important sources of uncertainty facing St. Louis decision makers right now, including the potential for these new variants to become widespread, to prioritize a set of policies to simulate that are of the highest relevance to St. Louis specifically, as opposed to potentially other places in the country. And then we actually undertook to test this model by retrospectively recreating the experience of St. Louis back in the fall in the model to show that the model can match up with reality. In the St. Louis specific version of TRACE, we were able to leverage big NIH investment in things called synthetic populations, which is pretty fancy sounding. What it really means is an individual level representation of the entire St. Louis metro area in detail. This entire part of the region that I'm showing on this map here, St. Louis City and the 7 surrounding counties, with about 2.5 million individuals, for each of whom we have realistic geospatially situated residences, workplaces, and schools. They're not real people's actual addresses, but they're virtual people's locations, workplaces, and demography that are statistically representative enough to be a very realistic depiction of the distribution of these things in St. Louis itself. So this is an example of a satellite view of the kind of detail that the synthetic population offers us. This is the immediate city surroundings with each of these tiny little pixel dots is an individual in the synthetic population, and the color coding, the shading here represents different ages in this population. And then we could simulate in this entire metro region the spread of COVID-19 through time under many different assumptions. And what we actually looked at were over 1,000 different combinations of policy elements covering testing of multiple types in and around St. Louis, contact tracing in and around St. Louis, business closures in and around St. Louis, and the effectiveness of mask policies in and around St. Louis. Those were the key things that we looked at. And we covaried all of these with epidemiological scenarios representing different assumptions about whether new variants are present and whether they become widespread and how contagious they are, for a total of over 50,000 different simulations. And again, many more results than I can talk about in the time I want to allocate to the presentation versus the discussion, although I'm happy to go into more in the Q&A and be joined by my colleague from the city to do that. But I want to stress three key themes from these results just to give you a sense of them. The first is that current control measures are working in the St. Louis region, and we project will continue to work if infectivity is low. If, for example, these new variants that you've heard so much about do not become widespread. Under this scenario, we show that cases will slope downward, as they have indeed started to do relatively recently, and that they'll reach zero by about 6 months, with a final cumulative infection rate a bit higher than today's level, but not dramatically higher. And this is true even if businesses are open and we make relatively modest assumptions about how many people are wearing masks effectively. But we simulate that if these new variants do become widespread and cause infectivity to go up substantially, then in fact, the current approach will not contain a potential large fourth wave from occurring over the next 2 months or so. And that would produce a large increase in the amount of total number of cases that we see in the St. Louis region from today. The good news is that the model identified 4 different, actually more than 4, but 4 that I'm going to talk about, different options for increasing control over COVID that would satisfactorily offset the high infectivity of these new variants, that would control the spread of even the more virulent forms of COVID that are emerging. One of those would be to increase investment in the region in contact tracing, using perhaps some resources that might come from the federal government. And we find that reducing, that this could reduce cumulative infection rates substantially if we invested in contact tracing capacity alone. We find similarly that increased investment in testing, and particularly testing and contact tracing together, echoing our national level results, can be a very effective way to control the spread of infection. We also find that restrictions on in-person business activity could contain the spread of high infectivity variants, but only if it's region-wide. If it's undertaken only by the city, it's unlikely to unilaterally be able to control the spread of these new variants, given the mixing that goes on between the city and the surrounding region. And finally, and actually of particularly high interest, I think, for this audience and for policymakers in the region, we find that increasing the level of effective mask usage in the St. Louis region could really contain these high infectivity variants, even without changing anything else that we're doing. And so what we did here is we varied 2 different things. One of those things is what % of the population is regularly wearing masks when they're outside their home and in public. And the other is how effectively are they wearing those masks? And as we've seen from recent guidance from the CDC, you have to wear the right kind of mask, and you have to fit it right properly and wear it over both your nose and your mouth and so on. And so what we did is we varied the ratio between sort of the best a mask can do in a carefully controlled lab setting and what's actually happening in the real world. And we covaried those 2 things, and we found that the difference between low mask adherence and low rates of wearing them effectively in the upper left corner, which shows a very high cumulative infection rate of 43%, and high adherence with high effectiveness down in the bottom right corner of 11%, that's an enormous difference in the amount of infection that would be projected to occur. So mask wearing, particularly important at this point in time as we wait to see whether these new variants are going to become widespread or not. There are many more results. For this work also has its own website with its own version of this dashboard where you can dial in different policies and different assumptions about the underlying epidemiology and assumptions about the virus, and watch the results redraw themselves. And I'm happy to send this a link around later also. What are we doing now with this TRACE model? We are looking into applications to other state and local settings, like we adapted the national model to St. Louis. We are using TRACE to do a deeper dive into sources of disparities and solutions to those disparities. And we are using TRACE to think about lessons learned from this pandemic and how to be more prepared as a country and as a region in the future, should things like this occur. I want to make sure before I stop to thank Open Classroom for inviting me to do this, to thank Dr. Eccles and the entire St. Louis Department of Health, including my colleague Matt Haslam there, who is going to join me in just a minute for some questions and answers with the audience. The entire TRACE team who put a lot of work into everything that I showed you at both WashU and Brookings, including Matt Kasman, Rob Purcell, and Joe Ornstein, my colleagues, and many stakeholder representatives from national, state, and local policymaker groups who we consulted and conferred with in designing and deploying this model to date. So I've hopefully left about 40 to 45 minutes for questions. And so I'm going to end screen sharing and put us back into the panel mode, where I will be joined by my colleague, Matt Haslam, who's an epidemiologist with the St. Louis City Department of Health, who was very involved in the St. Louis portion of the work that I showed. And together, we would love to answer any questions that you in the audience may have. I'll ask our moderators to manage the flow of questions and answers, and hopefully we'll be able to end on time. Thanks very much.
Well, Ross, thank you so much. That was a whole lot of information very quickly, but ultimately, I think kind of an optimistic view of what's possible with some caveats. There was a question coming in from Elizabeth in the audience, and you may have addressed this a bit with the synthetic data that you referenced, but she's curious about the data collection and whether it was ever at really the individual level, real people's real data, privacy, and any trust issues, or was it always at sort of an aggregate level where it was not, whether it was either statistical but hypothetical? Anyway, anything that you'd want to share about that?
We did not handle any real people's real data in this project. We had data in three different forms, actually. One of them are from published studies in the literature, which tell us things about, for example, how effective a mask can be, how much asymptomatic spread is going on. Those are based on real data, but we did not have access to the real data. We relied on the published study to draw estimates of those things for many of our parameters. And again, we swept a wide range of those to account for the possibility that any one of those studies might be wrong or might have had a limited sample or something like that. The second source of data was data from this synthetic population, which is a big NIH investment that they made actually 10 years ago during the last pandemic that we had, the H1N1 pandemic, which my team was also quite involved in. And at that time, this entire network of NIH researchers that the federal government invested in helped give input into the design of these synthetic populations, which were undertaken at the Research Triangle Institute in North Carolina. And they draw on data sources like the census and many other data sources and combine them in ways that allow us to represent at the individual level very statistically representative pictures of places, including a lot of geography, but without the privacy concerns, because they aren't real people's data, they're synthetic data. And so we get away from many of those considerations. And then the third source of data that was very important for the St. Louis models were data about what is actually happening in St. Louis. How many people have COVID? How many people have had COVID? How much testing is going on? And in many cases, that data is not completely aggregate in the sense that it's not for the entire St. Louis region, one number. It's at, for example, the level of the zip code and things like that allowed us to get the spatial element more accurate. But again, it's de-identified from any individual level data, and that data came from our colleagues in the health department, who of course can talk more about how that data was collected. Matt, do you want to add anything to that?
Yeah, it's a great question, Elizabeth, and thanks for raising it. In both research on the research partner side with Dr. Hammond, and then the public health side, we take privacy very seriously for our constituents and you know, people that we are modeling about. So like Ross said, most of the data that was used is synthetic, so it's not real people, or is informed by real people. For instance, the total case counts by county, by date, but it's, like Ross said, it's de-identified or aggregated to the zip code level. So, and most of it is, you know, publicly available on various you know, dashboards. You know, the city of St. Louis has their own COVID dashboard, and then other surrounding counties do as well.
Hey, I have a question for you, Dr. Hammond. Would you tell me, please, to what extent does the modeling techniques that you use help attend to issues of disparities and equities? How is that attended to?
Sure, that's a great question. One of the, I purposely did not go into a lot of detail about sort of the underlying technical parts of the methods that we use, but I alluded to this very briefly earlier. An important distinction between our approach and many other modeling approaches that are out there that have been used to good success with COVID is that we do not aggregate people into groups in the model and treat them all as the same within those groups. We actually represent each individual in our model separately. And that means that we can have as much diversity between those individuals as we want. And that means in turn that we really can talk about disparities and address those in a more meaningful way than some modeling approaches are able to do. And that is actually a critical part of the approach that we used to be able to do that.
Could you please talk a bit more about the decision support tool? I looked at the three components that you listed, and I'm most interested in expanding on how the decision support tool, how the modeling is used in that context.
Sure. Right. So so let's say that you are a policymaker and you are considering whether to open schools or not in your region, and you'd like to know what will happen if I open schools and what will happen if I don't open schools. Well, the answer to that almost certainly depends on a lot of assumptions about the world and about COVID in particular. They depend on assumptions about how contagious COVID is in children. It depends on assumptions about, you know, what kinds of adherence to things like mask wearing and hand washing you can expect in schools. It depends on lots of different assumptions. And for some of those things, we're not sure what the answer is. And so that makes it hard from a policymaker who's relying on sort of a mental model of how the world works to figure out how big is the gap between, how risky is it to open schools? How big is the gap between what will happen if we do and what will happen if we don't? And so what we can do in a model is that we can actually simulate opening schools or keeping them closed, and we can vary all of those assumptions that I mentioned over a huge range. So we can have 16 different scenarios from what the CDC calls its worst case scenario to a very optimistic scenario where there are no bad variants and everybody does what they're supposed to all the time, and everything in between. And then what we can say to a policymaker is, for some things, it might turn out that even in the worst case scenario, they're still okay. They'll still work. For other things, it matters whether we're sort of 50% of the way to the worst case scenario or below that, but there's a sharp threshold, which we might be able to sort of guess with data how close we are to that threshold. And for others, it matters tremendously exactly where you are on that continuum. And so we can't add any information. But already that's a whole lot more to act on as a policymaker than just, well, these things matter, but we don't know how. And so that's the role of models as decision support tools when you have uncertainty. And that's, I think the use of models and the visibility of them here in our public health arena is much more visible to the general public than it was a year ago. But this kind of use of models to manage uncertainty is by no means limited to health. They're used in engineering, in car crash simulators, in flight simulators. They're used in physics. They're used in biology. They're used in all kinds of settings to manage uncertainty. That's a core capability of models.
Yeah, just to expand on that a little bit more, from the public health perspective, that we have to balance, some of those tough realities in the political landscape and the testing and tracing landscape. So one of the benefits of doing modeling work like this is trying to identify, like Ross mentioned, policies that are robust in many different situations. And we can use simulations to sort of help us strike that balance between placing restrictions to limit people's mobility and interactions to reduce the spread, while keeping our economy open and such things. So one of the interesting results from this TRACE model was the close of businesses. And what was striking is if only the city closes businesses to the general public, but the surrounding region does not, it doesn't impact the spread that much. Whereas if it's a region-wide effort to close businesses, it's very effective. So it helps put the pandemic landscape into context within your own jurisdiction, but with the surrounding region as well. So it's very helpful from a policy perspective to get that sort of information about which policies are robust and which ones you can implement on your own that are effective, and which ones that need more widespread collaboration.
Yeah, actually, that's great. I just want to jump in to add one thing to what Matt said that sparked for me, which is an interesting thing about the St. Louis region in confronting public health policy here, is that it is a metro region that crosses many jurisdictions and many different municipalities, actually as is Washington, D.C., where the Brookings Institution is based, where I've also spent a bunch of time. And in that context, one of the sources of uncertainty, if you're a policymaker here in the city or there in the District of Columbia, is what the other policymakers will do surrounding you, which you may not have control over. And so again, you need to find these policies that are robust and understand which things are dependent on other assumptions and which things aren't. And that's the way in which models can help there.
First, I want to say to Matt, I imagine that you have worked some very long hours over the last year. Certainly our healthcare workforce has justifiably gotten a lot of attention for the tremendous sacrifices and just the heroic efforts. But our public health workforce has definitely also stepped up. So personally, as a resident of the area, I wanted to say thank you. I'm curious for anything you want to say about that. And then I'm also kind of curious, anything that you're able to sort of share behind the curtain. We've talked about the importance of a regional response for certain policies, but what has this modeling, this work with Dr. Hammond, allowed you all to do differently than might have been the case otherwise?
Yeah, thank you for the recognition. The public health sphere has been definitely tasked with stepping up to the challenge, and my colleagues, both within the city and surrounding jurisdictions, have really stepped up and have been working long hours, like you say, to meet the need. And especially now as vaccines are rolling out, people are definitely working overtime to get shots in arms. So appreciate the shout out there. And then this modeling work has really had a lot of interest with our Board of Health and policymakers. And it has really sort of reassured us about the course that we have taken with respect to the policies that we've put in place. And like Ross mentioned with the initial results, the current policies in place are sufficient to reduce the spread of COVID-19, so long as the assumptions remain relatively consistent and the new variants don't take hold. So again, it's critically important that we continue those efforts. And as vaccine sort of ramps up, to continue social distancing and wearing a mask and all these things. So it's really informed us about which policies are effective in the context, like I mentioned before, about within the city, but also as a region-wide effort. So more than anything, it's reassured us that the course that we've taken is appropriate, and it has lent some evidence to support those efforts.
To both of you, I'd like to pose this question, doing my best not to sound cynical. How much does politics or popular opinion influence modeling? That's a sincere question. How much or what steps do you take to make sure that it doesn't influence the techniques that you use and your outcomes?
Yeah, that's a great question, and something one always has to be aware of. We work hard to be independent scientists, to keep our approach, our methods, and our results transparent and broadly accessible, to be peer reviewed, and to keep them independent from those kinds of influences. And we go through a number of standard best practices to do that. That said, with policy work, I do think that it's very important for modelers, for people aiming to build models, such as myself, to actually engage early in the process with the policymakers who are ultimately the stakeholders who are going to benefit from those models. And in some sense, you do have to shape not the results, but the set of things that you look at to their reality. In a situation, there's no point in simulating model, and a policy that is never going to be feasible in the real world, or that is going to be completely politically unpalatable. And so if your goal is to be a support to policymakers, that does shape a little bit the focus of the work. But then the way in which you carry out that work and the results remain independent from those influences.
Right, like Ross mentioned, we have to be, well, the other consideration with modeling efforts is, like Ross mentioned, it sometimes doesn't make sense to model certain, policy situations. Like for instance, once the lockdowns ended and we were several months out, and many places were relaxing restrictions, going to a full shutdown again was likely a political non-starter. So, and not recommended in general. So it's not really worth spending the time to look into it. But the other sort of consideration with modeling is the computational requirements. So Ross mentioned that we did 50,000 simulations. And so there are some considerations that need to be taken there to focus on what is likely to be informative once the results are output. And then just the time and effort required just from a computational perspective sometimes limits the amount of variations and sort of complex patterns that you can analyze.
But yeah, I'll just add one other thing, which is that I think it's always a best practice to be transparent, but it's even more important for things that are public global emergencies like COVID. And I actually published editorial piece with a number of other modelers, colleagues in science, that was a call to transparency for COVID models. And actually, unfortunately, there has been a high variance in the degree to which people who are modeling COVID are willing to be transparent about how their model works and what's in it and what assumptions they used and what data they used. And I think that's just absolutely critical to avoid the kinds of considerations that concerns that you mentioned.
So I'd love to ask either or both of you what's next for this work. You mentioned other geographies where it might be applied, but we're not quite done yet. So what's next?
Yeah, I mean, I'm happy for Matt to talk about what's next in St. Louis in particular. I think one of the things that we're really interested in doing, besides continuing to support state and local policymakers in figuring out this next period of actual response to the ongoing pandemic, is to then eventually transition to thinking about the future, thinking about lessons learned, thinking about what could have been done differently this time, thinking about things like disparities and how those could have been ameliorated earlier in the process, but also thinking about how we as a country should prepare for future challenges, be they other pandemics, which could certainly happen, or many other challenges that predated COVID and will continue after COVID is a memory. And I think that the TRACE model in particular and this approach to modeling in general have a lot to offer in thinking through those questions. Matt, you're still muted, I think.
Sorry. Yes, just to add from the city's perspective, right now, obviously, we're very focused on vaccination. So one potential sort of addition to the TRACE model is just to have a more specific pattern of vaccination across the city based on zip code and geography, rather than sort of a random age-based allocation to represent closer to the reality. So that could be an interesting follow-up. And then kind of like Ross mentioned, just looking forward to taking lessons learned from this pandemic and putting protocols in place to meet the challenge of the next pandemic, which hopefully will be in another lifetime. But as we have seen, it probably won't be. So just taking those lessons learned and moving forward. And then keeping the collaboration with our academic partners, like Dr. Ross Hammond and others across the healthcare system. So the City of St. Louis is actually collaborating with other health partners across the region with the the St. Louis Regional Comparative Modeling Network, which is a group of academicians, health partners, and local public health jurisdictions who come together and compare models, specifically regarding COVID, but going forward, hopefully we're going to keep the collaboration going and model other inequities across the region and other health outcomes.
I'd like to ask both of you, have you ever encountered a scenario in which you have you've used these techniques to model and the lived experience was completely divergent from what you expected? And how did you respond?
Sure. Models don't always get it right, and models don't always represent the aspects of lived experience that everyone who is potentially a stakeholder finds most salient. If they were perfect, they would be much more widespread than they are. But that said, I think you always have to think about whether any model with all its limitations is an improvement over the way in which decisions are made before that model existed, whether they're adding value or not. And even if they're imperfect, they may still add quite a bit of value. We've actually found that not necessarily with this COVID model, but with many other models we've done, that the journey of building the model with policymakers, with stakeholders, and seeing it evolve over time to adapt to new uncertainties that have been unmasked, like new variants and so on, is very valuable in and of itself, because it forces everyone who's party to the process to actually be explicit about what their assumptions are, why they think they're important, what their view actually is. And many of those things are often implicit in people's minds, and models force you to make them very explicit, and that has a lot of value in and of itself.
Yeah, and just to go off that, if there are discrepancies between what the model is predicting or representing and the lived experience or reality, that can often be very informative. And it causes us to take a deeper dive into what's really going on. So there could be a critical variable that we're missing in the model that should be included. And like Ross said, it's an iterative process, and we improve as we learn more to try to get closer and closer to sort of that true representation.
Thank you both.
So I know you both are involved in training others, working with students, various ways that people who are interested in this methodology and other modeling can get up to speed. So I'd love to ask you a little bit more about that work that you have, either educating MSW and MPH, MSW, PhD students, or trainings that are available to folks that are interested from a policy or academic scholarship perspective.
Sure, yeah, I'm happy to speak to that. So I am on the faculty at the Brown School at WashU, and I do teach a graduate course there that is specifically focused at a semester length on the technique, the mathematical computational technique that I used for all of the TRACE work, which is called Agent-based Computational Modeling. And that is a PhD course that is also open to advanced master's students in any of the master's programs at the Brown School. So I certainly encourage anyone who's at the Brown School or thinking of coming to the Brown School to look into that. That's actually complements other courses that are also offered by the Brown School in a whole constellation of related techniques that are called system science, of which agent-based modeling is one, but there's others: network science, system dynamics, a number of related techniques that the Brown School really has a strength in. So that's one thing. And then the other thing that I wanted to highlight briefly, since you brought it up, is that we do run a summer training institute at the Brown School, which is open to anyone in the world to sign up for, which is an intensive 1-week workshop that gives you a first introduction to one of these computational system science tools. And it does not necessarily assume you have a mathematics background or even a statistics background. And it's actually related to a course that I used to teach at Harvard, and before that, that NIH ran a summer institute like this that we've actually modeled ourselves after. And I've had many students take those versions of the course that are practitioners, that are public health officials, or that are policymakers, as well as students and even faculty in different disciplines. And so I would encourage everyone to who's interested in potentially in these tools to take a look at that. It's called Systems Science for Social Impact, SSSI, and we have a website which we can put in the chat for that. Matt, do you want to add anything?
Sure, yeah. So the Department of Health often accepts MSW or MPH students for their capstone projects or practicum requirements. And so I've been working on and off with the Brown School for the last year and a half or so, specifically with Ellis Ballard's group doing social systems dynamics. So creating causal loop diagrams, et cetera. And we're engaging an additional class of students this semester to collaborate with our comparative modeling network. So we're excited about that, to explore more about the system science surrounding COVID. And then I recently completed a project with another Brown School student with an environmental health project, which is typically my concentration when there's not a pandemic sweeping through the nation. And that project revolved around demolition and lead dust exposure in the city. So there's lots of data available. So we definitely encourage MSW and MPH students or PhD students for that matter to reach out, and we might be able to find a project to satisfy requirements. And then we also are an academic health department. We've got a collaboration with the various universities in the region to collaborate on certain projects, varying from COVID to environmental health to women and children's and adolescent cancer and all sorts of other things. So we really try to run the gamut and provide a good experience for the students. And they provide great help for us too to understand our city better.
It's wonderful. Lots of great opportunities. I appreciate you giving those invitations to folks. So this always happens. We can make an hour go by so quickly, and we've really done that. I'd like to, before we sign off for today, give both of our speakers an opportunity to provide a closing thought or comment to the audience. So you guys can rock, paper, scissors, who wants to go first, but whatever you'd like to leave our audience with.
You go first, Matt.
Okay, I was gonna let you have the last word. So thank everyone for joining today. Hopefully that was engaging and educational. I just want to have everybody stay the course, get vaccinated, wear your mask, social distance. There's a light at the end of the tunnel here, and we just need to stay the course. So please continue on and keep our city safe. So I'll leave you with that. Thanks very much.
Yeah, I would echo that. I think the results from all the modeling I've done on this suggest that there is light at the end of the tunnel, but that we're not quite out of the tunnel yet, and that we need to keep up all of these measures, and particularly the mask usage is quite important in the results that we talked about today. And I would just also add that I have spent a lot of the last several decades of my career at this intersection of policy and models and the kinds of techniques the scientific techniques that I showed you today. And I really believe that this partnership between decision makers and modelers is a very fruitful one for tackling a lot of hard problems in our society, not just COVID. And I hope that if you take anything else, just one thing away from today, it's that this is an interesting and innovative way to try to tackle very complex and uncertain topics.
Wonderful. Well, thank you so much for this work. Thank you for spending the time with us. I hear what you're saying. We're not done yet, but it is so heartening to know that if we stay the course, all the evidence suggests brighter days are coming. So let's not lose our resolve now. Thank you to Ross and Matt. Thank you to my co-host Cynthia for this program. For our audience, as always, we appreciate you. And please stay healthy and safe out there, everyone, and hope to see you at another program very soon. Take care and have a good day, everyone. Bye-bye.